All right, let's get right into it. We're talking orthopedic triage today. This is a super high-yield crash course designed to get you ready for your exams and for the chaos of a busy clinic. The whole point here is learning how to make the right call and make it fast.
So here's what we're going to cover. First, that big initial question in any ortho triage situation. Then we'll hit the red flags you absolutely cannot miss. After that, what to do in primary care, the tools you'll need, and finally, we'll put it all to the test with some classic exam cases. Let's do this.
Okay, first things first, the big question. This is all about deciding a patient's path in those first 5 minutes. So you've got a patient with an acute injury. What's the very first thing you have to decide? It's not just what's the diagnosis, right? It's really about where does this person need to go, like right now. That's the whole game. I like to think of it kind of like a 2-lane highway. You've got the local lane, right? That's for your stable injuries, the ones you can manage in primary care with some splinting, rice, and a follow-up plan. But then there's the express lane, and that one goes straight to the emergency department. This is for anything unstable, infected, or anything that threatens the limb, circulation, or nerves. Your job is to be the traffic cop and get them in the right lane. Immediately.
And that brings us to maybe the most important part of this whole thing, the red flags. These are the send to the ED, do not pass go situations, the must not miss diagnoses that will for sure show up on your exams and, more importantly, can save a limb in real life.
Okay, let's talk about things that threaten the limb itself. If you see bone breaking through the skin, that's an open fracture. It's game over. They go to the ED. Simple. See a really obvious deformity, especially if the skin is stretched tight over it, what we call tenting, same deal. And you have got to check your neurovascular status, pulses, sensation, movement. Anything off there is a huge red flag. And of course, the big one, compartment syndrome. The classic board question is going to be pain out of proportion. If you see that phrase, your brain should be screaming compartment syndrome. It is an absolute limb-threatening emergency.
Next up, let's talk infection. Septic arthritis is a huge one for exams. You're looking for that hot, swollen, super painful joint, usually with a fever. And the key piece of the puzzle, the patient literally cannot bear any weight on it. That's a trip to the ED for a tap, no question. Also, keep an eye out for nasty hand infections, especially a fight bite. That's a clenched fist injury over a knuckle, and any deep foot infection on a diabetic patient. Those can go south fast.
Last but not least in our red flag tour, spinal and high-risk peds. Cauda equina syndrome. If you see saddle anesthesia, urinary retention, or bilateral leg weakness, that's a drop everything and call neurosurgery situation. Don't miss it. Now for kids, 2 big ones you'll see on boards. First, a suspected SCFE. Think overweight teen with groin or knee pain. The absolute most important first step is making them non-weight bearing, period. And second, a nasty elbow fracture, the displaced supracondylar humerus fracture. These have a super high risk of nerve and artery damage.
Okay, so we've covered all the scary stuff that needs to go to the ED. Let's switch gears and talk about the stuff you can and will manage in your clinic. This is your initial playbook. So for your bread and butter ankle sprain, just remember RICE, or even better, police. That adds protection and optimal loading. For a mallet finger, it's all about that continuous splinting in extension for weeks. A simple clavicle fracture in the middle of the bone, a sling is usually all you need to start. And of course, the classic nursemaid's elbow in a toddler, you do that quick hyperpronation reduction, and it's like magic.
All right, to really nail this stuff, you need a good diagnostic toolkit. You got to know the rules for when to get an x-ray, and you have to know which splint to use for which injury. Let's dive into some of the most high-yield tools you'll use.
Okay, this is a big one, the Ottawa knee rules. Why are these so important and so heavily tested? Because they show you know how to be a smart clinician. You don't just x-ray every single knee. You use these rules to decide. If your patient checks any of these boxes, they're over 55, have specific tenderness, can't flex to 90, or can't bear weight, then yeah, you get the x-ray. If they don't meet any of them, you can be confident holding off on the imaging.
And here's your high-yield splinting cheat sheet. This is pure pattern recognition, and examiners love it. You just have to know these cold. A distal radius fracture, like a Coley's, sugar tongue splint. Suspected scaphoid fracture, thumb spica. Every single time. A boxer's fracture, ulnar gutter splint. And a ruptured Achilles, you're putting them in a posterior splint with their foot pointing down. Memorize these pairings. They are free points on an exam.
Okay, time to put it all together. Let's walk through a few classic cases. These are the kinds of scenarios that are practically guaranteed to pop up on your boards and, for sure, in real life.
So here's case number 1, an absolute classic. A patient takes a fall,
lands hard on their outstretched hand, the classic fauche. You examine them, and they're tender right in that little divot at the base of their thumb, the anatomical snuff box. You get an X-ray, and it looks totally normal. So what's the move? Be careful, this is a classic exam trap. The one and only correct answer is this. You treat it like it's broken. A negative X-ray right after the injury means nothing when it comes to the scaphoid. It's famous for not showing up right away. So your immediate next step is to immobilize that wrist in a thumb spica splint and tell the patient they need to come back for more imaging. And here's the magic number they love to test you on. 10 to 14 days. That's the window. You bring them back in 10 to 14 days for either a repeat X-ray or, even better, an MRI, to see if that sneaky fracture finally shows itself. Don't forget that time frame. Okay, next case. You've got your classic weekend warrior, maybe in their 40s, playing some basketball or tennis. They plant their foot, push off, and bam! They feel a sudden pop in their lower leg. The story they almost always tell is, I thought someone kicked me in the back of the heel, but when I turned around, nobody was there. That history is practically pathognomonic for an Achilles tendon rupture. You can often diagnose this without any imaging. You've got the story, you might even be able to feel a little gap in the tendon where it tore. But the money shot on physical exam is the Thompson test. You have the patient lie on their stomach with their feet hanging off the end of the bed. You squeeze their calf muscle. On a normal leg, the foot will point down. It'll plantar flex. But with a ruptured Achilles, you squeeze, and absolutely nothing happens. The foot just lies there. That's a positive Thompson test. Management here is urgent and has 3 non-negotiable steps. 1. Splint them immediately. You use a posterior short leg splint, and you have to put the foot in what we call equinus, which basically means pointing the toes down, to take the tension off the tendon. 2. They are strictly non-weight-bearing. Crutches, no ifs, ands, or buts. 3. You get them an urgent orthopedic referral.
All right, here's a classic exam showdown, the hot joint. Is it a septic, infected joint, or is it just a really bad gout flare? They can look similar, but you have to tell them apart. A septic joint is an emergency. The patient is usually sick, fever, feeling terrible, and here's the key. They cannot bear weight. Gout hurts like crazy, don't get me wrong, but they can usually still manage to hobble. Getting this one wrong can destroy a joint, so you gotta know the difference.
So, look, if you're cramming for an exam and you can only remember a few things, remember these 3. These are your absolute never-miss orthopedic emergencies: compartment syndrome, septic arthritis, and cauda equina syndrome. Know how to spot them because they have devastating consequences if you miss them, both in real life and on your test. So there you have it. That's the framework. It's all about systematically hunting for those red flags first. Once you've ruled them out, then you can move on to your toolkit for management. You've got the knowledge now. The only question is, which one of these red flags are you going to catch on your next shift or on your next exam?